This communication skill for healthcare professional is the topic I have chosen for presentation today. This topic is communication skill is one of the core topics proposed by Nepal Medical Council for the for your mandatory collection of the CPDs. All other points you can gather from your own respected specialty training, but there are 5 core topics which are required to be obtained from the Nepal Medical Council personnel, and the 5 topics are infection control, communication skill, medical ethics, CPR, and the rational use of antibiotics. These are the 5 core topics. So I have chosen one of these topic as this is very relevant, and with the increasing number of increasing awareness of the patients and so-called consumer right groups, it is extremely important for us how to communicate well with the patients, well with our colleagues, well with the administrators, well with our hospital worker, hospital seniors and juniors, and to communicate with the attendants, sweepers, and all kind of healthcare manpower. So this is the reason we need to be well aware of this. But this is the this could be the one of the reality. This was said by George Bernard Shaw. The single best problem in communication is the illusion that it has taken place. Most of the time, we think that we have communicated well with the patient, well with the family, or well with our senior, but actually it has not happened. We only assume it has happened, and later we find that the communication was the most important part where we lacked and the misunderstanding happened. And this was said by George Bernard Shaw a while ago, but it still holds true in today's time. So in any effective communication, there are 4 things that happen. First is what I wanted to say. This is the thing that goes in my frontal lobe. So this is a big circle, what I wanted to say. Then the circle becomes little smaller, what I wanted to say and what I actually said. There is already some filtration of the information because our language, our vocabulary are not rich enough that whatever we wanted to say, we cannot actually say. It has to be condensed in, and it automatically gets condensed in smaller form. And then this is from my side, and then what you hear, then there's somebody else. If I communicate something to somebody else, then the person what I say and what he or she hears, automatically the circle becomes a little smaller. There is already some attenuated information from there, and then what the person said and what the person actually interpreted, the circle even becomes smaller. So what I actually wanted to say is this, what actually the person interpreted is this. Even if we do proper communication, imagine if we do not do proper communication, then this circle will become extremely small and can be distorted. Instead of becoming the circle, it can become rectangle, and then the miscommunication happens. Why we need good communication skill? This is the thing, the reason we need to know. Based on one study, on average, one doctor or any healthcare professional spends about 55% of their total time in their life when they are active as a doctor. They spend time talking with the patient. So something in your life you spend for more than 50% of your time, obviously you have to be good at it. This is the number one reason why we have to know the good communication skill. Next important thing is it facilitates healing. If the patient has a problem and if you communicate the patient's problem, your treatment modalities, your prognosis of the patient well, it helps patient heal the trauma of the bad diagnosis, trauma of the surgery, trauma of the getting chemo, radiotherapy. This all is helped by good communication. Third is it helps the patients cope with stress. If somebody has a non-specific headache, we order a CT scan. CT scan shows a huge tumor in the brain, maybe meningioma, maybe glioma. Then if you do not communicate well, then the patient will have a lot of stress. But patient will have a, negative, patient will be kind of in shock when you break the bad news. But, your good communication will help that patient to cope with the stress. And another thing, this is the era of empowerment of many many sector of the population, and the patient also feel that they also should be empowered to make the decision to to be the part of the clinical decision making. And when patients feel that they are empowered, and then the ultimate outcome will be good. So this is another reason why good communication is good. And the last part, it was based on the large case studies in the United States. If you had communicated well with the patient before surgery or before doing any intervention, the chances of that patient or the family litigating you is much less compared to if the communication was not there beforehand. For example, even if there was a mistake, if you give overdose of a drug, or some surgical error was there, if you leave a gauze pad inside the surgical site, and if you disclose that to the patient, that patient will be little lenient to you compared to if you hide the information to the patient. So these are some of the reasons why good communication skill is extremely important in our career. So in the communication is not a stamp, it's not a cross-sectional thing, it's a longitudinal thing, it is a process, it's a dynamic thing. So it goes through a source, somebody source. For example, right now I am the source, then I construct a message, and that message I have to encode. There are many ways of encoding, how encoding the message, we'll go through that. And I encode that, and again after encoding I make a message, and I use a channel. Right now I am using my laptop and the Zoom software to make the channel. And then from that channel, the message will go to another receiver, and the receiver will decode my message, and then they will receive and interpret. And sometimes, and then then I will get my message across there, and depending upon their feedback, then I can, during the process also, or after the process also, after the end of this communication process, I can improve upon myself. For example, if I get at the end of this presentation, if I get feedback from the audience, then when I do this same presentation after 1 month, maybe I will improve on it. So this is how the whole communication happens. So communication is never a one time, it's a snapshot thing. So let's talk about the source. The source person should fulfill these three criteria before the person commits to send the message. Number one is why it is needed to communicate. That is to be needed. That has to be taken into consideration. Most of the politicians don't give give importance to this. They just communicate even if they don't have any message to say. This is not a good thing, maybe. And what to communicate? Once you have decided you needed to communicate, next thing is you have to have enough material to communicate. If you don't have any material to communicate, then you are not a good source. And third is you have to give the material, the information which should be very accurate, and it should be useful to the audience. If the material, the information is not useful, it will be very hard to get the attention of the audience. So these are the three things the source person should keep in mind. Next is the encoding thing. So encoding is basically nothing but the creation of a message. Now I have something in my mind, and then now, so there is a patient whom I sent a CT scan, and the CT scan report comes suggestive of glioblastoma multiforme. Then I have already made something in my mind, but I have to create that message, create a paragraph or something that I have to communicate to the patient or the patient's family. That is what the encoding is. So while encoding the message, we have to eliminate the sources of confusion. This is important. Sometimes the patient family say that, okay, doctorले त यस्तो भन्नुभयो तर मैले भनेको चाहिँ खासै बुझिनँ, त्यो भन्ने कुरा हुन्छ. There are three confounding factors why that happens. There could have been some cultural issues. If there are some mistaken assumption, सानो मासु पलाएको भन्नुभयो, ट्युमरको त कुरै गर्नु भएन भने पनि there was mistaken assumption. and then some missing information. If we have to describe, we have to communicate well, then we have to give them accurate, succinct information that has to be constructed before we deliver that message. And sometimes, and the language is another important thing, when we communicate with the patients or family, most of the time we use English words mixing with Nepali, and the majority of the people may not understand few English words which are so natural for us to say that. So while we take consent for surgery, especially, we have to talk to the patient's own language. Same thing with research also. When we recruit the patients or the research participant for the study, we have to get the informed consent, and then we have to talk in the patient's language if we have to get the informed consent for the research, especially if it involves risk or randomized trial. Like this is the example of we used to show in the live presentation. This is a t-shirt, and we could ask how many holes are there in this t-shirt. See, different people may give different answer, and actually this t-shirt has 8 holes. Some say 6, some may say just 2, some may say 4. The idea of showing this slide is to, while communicating and constructing the message, we have to avoid confusing things. It has to be in a most straightforward and unambiguous way. We have to construct this message. Let's go to the channels. So there are basically 3 channels we use in our life to communicate with other people. Most important is the verbal channel. Verbal channel could be in the form of face-to-face interview, while we do discussion or we do live presentation, or when we see the patients in the clinic. That's what we do, face-to-face interviews, or when we take exam also, this is kind of face-to-face interviews. Another is presentation. So presentation is also a type of verbal, and then video conferencing. And while we talk in the telephone also, this is a kind of verbal communication. Next is the written communication. Written communication could be in the form of email. We do not do that much in Nepal, but I have seen that in the United States, a lot of information is passed via email, especially among colleagues or sometimes to the patient. Another which has come up recently or from since 2000 is the social media, as you know, Facebook, Viber, Twitter, all these things. You can use that channel and get your message across. And third important thing which we do, we have a lot of room for improvement is the discharge report. If we discharge a patient from teaching hospital, and if we do not write in detail or the relevant information, and if that patient happens to visit another doctor, and if that doctor wants to find out what was done at teaching hospital, and we may not get the relevant information that we wanted. Or if we discharge a patient today, and after 1 year the patient comes for follow-up, and if we do not write good discharge report, then we do not know what was done to that patient. For example, if we do not write accurate histopathology report, or if we do not write what was the DSA finding, and then we'll be lost. So this is the reason why we have to do good, this written, use this discharge report as a channel to help ourselves, to help our other colleagues working with us. And third and equally important is the personal presentation. How you look, what is your body language, how confident you look while you are communicating, also shows, gives the confidence to the patient or the family or our junior or senior colleague, that what we are talking about. Sometimes when we say we talk with the family why you need this surgery or that surgery, if we use our bad body language, they will probably get negative impression of ourselves, that this doctor, I didn't have anything, he just said you need surgery and I'm not happy, that's why I come here. That kind of thing we all have experience. So body language is also equally important in this context. So these are the 3 basic channel we use for passing our message to the receiver. This is a learning pyramid I like to show you, also called cone of retention. How much information we retain based on the different type of channel we use. This model was first constructed by National Training Laboratories Institute in Maine, US in 1960s. Unfortunately, the original paper of this actually model has already been lost, but this has been passed on to the next and next generation. What it says is, if you just do lecture and only one side communication, the other person only listens, the retention is only 5%. It's a hopeless way. Just like I am doing right now, is the worst form of communication. In fact, if you read something, you retain 10%. If you do use audio visual, probably we are doing little bit of audio, visual will be in the at the end of the presentation. And the best way to learn is teaching others. Probably I have taken advantage of this situation and I'm learning 90%. So some of you may be learning only 20%. Demonstration, we are above demonstration. So audio visual and little bit of lecture. So whenever you want to communicate something, learn something very well, the best way to do that is by teaching or communicating with others. This slide just shows that. So interaction is always better than one way or two way of communication. Sometimes we just say one thing to the patient and we do not get patient's feedback. This is exactly what happens. Let's go to decoding. Decoding is just nothing but the interpretation of the meaning of the meaning of the message. This is what exactly happens to the patient and the family. Sometimes they pretend not to understand. That also we have experienced that, we know in the morning one of our colleagues has explained in detail to the patient's family, and then suddenly we get phone call after 2 to 3 hours that, okay, this patient, we did not understand what the doctor meant in the morning. I want to listen to that again. That kind of thing also we have noticed. But sometimes if we do not talk in the patient's language or the family's language, they do not understand. So we have to use lay terms to explain the situation to the patient and the family. This is what the decoding means. It is of course subject to mentality and experience. If the family or the patient is already is negative, yeah, they have negative impression about you or about your hospital or about your department, then they, whatever you say, they will always get negative impression. Plus the experience, some patients say that, okay, if there is a patient with a PIBD, huge PIBD, patient comes to your clinic limping and there is a huge disc in the MRI, and if I suggest surgery, they would immediately say, okay, my kansaba mero kosko had operation and they did not do well, so I'm not going to do surgery no matter what you say. That's what their mentality and experience means. So that also we have to take into consideration. But there are some things that decoding helps. First thing is, you can be a source person, you can be the receiver. Like today I am presenting, the next week I will be listening. So if I am listening, I'll be
Timbro,
decoding the
paisa ko sa
information.
manya eh.
To decode the information
Ang paisa
properly, I have to listen to the things actively. If I am reading something, then I have to read it carefully. And we should not hesitate to ask question for clarification. Sometimes, when you are a very junior member of the team or in the junior resident, you hesitate asking question when you don't understand, and that is the worst way not to learn things. So if you are not sure of things, it's always better to ask questions. This is for effective decoding. Then how about the receiver? Let's go to the receiver purpose. Receiver is the audience to whom we send the information, and they are the most important part of the any communication. So the influences for the receiver, there are three things you should know in mind when you communicate with the receiver. So you have prior knowledge. How much prior knowledge the receiver has? Like for this today's audience, I know they are already through MBBS, already through the neurosurgery training, or they are part of the training. So I have made my presentation to that extent. And sometimes if there are bodily limitations, if the person is visually impaired or the person is hard of hearing, then we have to use alternative source to communicate with the receiver. And then third would be the surrounding disturbances. If there are surrounding disturbances, for example, there was already some sound, somebody did not mute and already disturbance, or if you are doing the live presentation in a very busy, if the seminar hall is very close to a busy street, then a lot of sounds from the street will also disturb the communication. Next important thing is the feedback. You remember that loop I showed earlier. Then last thing, after the receiver decodes the message and gets, then it's always nice for any civilized person to give good feedback. The feedback could be given either verbally or non-verbally. Verbally, you can say that, okay, this part is good, but that part you need to do this, or this thing. Or non-verbally, because by your body language we can understand whether you are paying attention, or you are enjoying, or you did not understand. All those things we can get through non-verbal thing. And the feedback can of course be positive and negative feedback. You can say positive things, you can say negative things. The basic funda of giving feedback is always start with at least one positive thing. No matter how hopeless the communicator was, you always start with one thing which you can always you find out to be positive. Then you can always say negative feedback. And this is one with the micro teaching is one of the essential components in higher level of training, higher MCS training, PhD training. Always you make presentation, you do the live presentation, and then you note down what are the things that needed to be corrected. You play you play the video again, and the teacher and the students sit together and watch the video together, and they both note down what are the points that needed to be corrected. That's what the micro teaching is, and the feedback is very important component in micro teaching. There are many barriers of effective communication. There are some of them I have listed here. Time could be a limit. You have a big material to deliver, and you have time constraint. Language could be another barrier. Noise, distraction, lack of interest. If the audience do not have the interest on the topic you are talking, then then the communication doesn't happen. If you use inappropriate medium, for example, if you want to show the technique of surgery to your resident, and if you do not use good video, then that will not the communication will not happen well. Disability, I mentioned, if somebody is hard of hearing or be impaired, or if you have a seminar hall in the top floor of a building and there is no lift, the person is paraplegic, the person will just not be able to attend the conference. That happens. And then disagreement between verbal and non-verbal message also, this is very important. If you are very excited, if you know the content very well, then your body language will also be very positive, as opposed to if you do not know the subject matter very well and you are very much struggling, then your verbal and non-verbal message are not congruent, and you will not be able to communicate well. Obviously, distance is a huge issue when you are doing conferences in the presentation hall. You have to be careful on how big your slides and all those things we talked a couple of weeks ago, that you have to make sure that the person sitting in the farthest corner of the room should also be hearing your voice and also be able to read your slides. That's the thing. Lack of self-confidence is there, other people time all there. I like to show you one. Okay, then I like to show you one video here and see. इकोलाई अलिकति ध्यान देऊ अहिले ठीक छ कि हेलो इको छ हामीले आवाज घटाउने होइन इको मात्र घटाऊ आवाज बढाउने इको घटाउने हामीले सङ्घर्ष गरेर आवाज अलिक बढाउँदै आवाज बढाऊ योजनामा राखेका छौँ कार्यक्रममा राखेका छौँ बजेट छुट्याएका छौँ र त्यसरी अगाडि बढ्दैछ Okay, so we just watched the video, and even the Prime Minister was speaking, and still there was a lot of problem. He wanted to communicate something very strong, but there was a huge barrier during the communication process, I think the audio was not working. There was an echo there, and then a lot of it made very embarrassing. But he's such a great orator. He could recover very fast. But if it happens to us that something goes wrong, then it will ruin our whole communication process. So I just wanted to give one example of how good communication sometimes can be interpreted by smaller things. Next important thing is the physical space. If we want to communicate with the patient, this is the in the context of the clinic where we want to interact with the patient and at least with one family member. The most important thing first is the privacy. We need to have a privacy when we want to discuss personal matter, patients, really confident matter with the patient and the family. Next important thing is we have to both the patient and the physician should sit down. If you stand and the patient is sitting down, then it is as if you are looking down upon the patient. You are degrading the patient's position. So should be at the same level with the patient. That's the patient or the whoever you are talking. And third is there should not be any physical barrier between, even if you can see the patient's face, but still if there are barriers, then that hinders effective communication. And if you are going to break bad news to the patient, they recommend a box of tissues, because patient or the family are going to be emotional in front of you, and then you have to kind of help and console them how to overcome the grief. So box of tissue or alternative thing is advisable. This is the typical example of the regular, at least government hospital clinic situation in Nepal. There is a doctor, is seeing the patient, there are a lot of paper here, and then everybody is trying to get his attention. I think he is too frustrated, so he's also not giving any attention to this crowd. And this is probably we are improving on this with time, but still this is not uncommon to see still. This is another example I want to show you. So the physician is was sitting here, the patient is here, our daughter is here. There are people walking around. This person is showing some curiosity. Doctor's face doesn't look very happy, and there are this distance is too far, and there are papers here, the litter in the table. So this is a worse way of doing communication with the patient. And she is also kind of scared. The daughter is kind of scared. This is just a mock for the sake of this presentation. I had taken this photo in our hospital. This is not the way I do the communication. This is maybe the better way. So there is no physical barrier. At least you are using the corner of the table. He looks happy. She is also comfortable. I is more or less at the same level, and both are seated. So this could be one example of at least having the good privacy and good environment to do the communication. Next is the proximity, how close you can go to the patient. So there are cultural norms which will dictate, how close you should be with the patient. Uh, and what they say is it should be comfortable distance. Recommended is about 2 feet, 1 arm's distance. If the person is too close, then it will be embarrassing. And if it is too far, then the person may not hear or hear well what you are saying. So the good distance is about 2 feet. And sometimes it should be guided by the signals of discomfort. If you are too close to the patient or too far away, the patient will give you some indirect signal that the person is not the communication has not happened really well. And next important, once you have seated down, you have the good physical space. Next important thing is to establish a good rapport with the patient. This is the most important thing. Everything else follows establishing good rapport with the patient. If your rapport was not good, we did beautiful surgery, we did everything possible, we gave our 100% of the effort, still the patient will not be happy, even if the person does well. Sometimes if we develop a good rapport with the patient, even if the outcome was not great, still they will thank you. So establishing rapport is very important. How we do this? we should first greet and welcome the patient. Almost always we say namaskar, aunus, bosnus. We always have to say that. Sometime in the busy clinic situation, just like the example I gave couple of slides ago, may not allow us to do that, but still, 5 seconds of saying namaskar will not harm any one of us. Should welcome the patient. And the next important thing is you have to introduce yourself. Don't take for granted that they will know you. You are not the biggest person in the world. So it's always nice to introduce, my name is this, I'm here to say you, what can I do for you? So these are the three things you have to say. And the third thing is clarify your role and nature of the interview. Sometimes we have a different layer of manpower in the clinic, in a first year resident, third year resident, junior faculty, senior faculty, and you have to say what role you have. If you are the first year resident, then probably you will be taking history and physical examination, and you will not be making ultimate decision about the care of that patient. Then what you should be saying is, okay, I am a resident in training, I'll be doing history and physical and all the lab tests, all this, and I'll discuss with my senior and we'll come up with the definitive conclusion regarding your disease. That's what we should say. Sometimes if you already say that, okay, you have got a tumor, you need surgery, and if your senior doesn't feel that surgery is the best way for that particular patient, then there is and we get confused. They say one doctor says need surgery, another doctor says need surgery. These both doctors work in the same hospital. What is this? That kind of message will go, and we should avoid that. And the next important thing, and I have been made full of myself couple of times, if there is a person accompanying that patient, we should always ask who that person is. Sometimes I have asked, is this your wife? And sometimes that doesn't happen to be. Sometimes the daughter will be there, sometimes girlfriend will be there. So don't presume the relation. Always ask who that person is, and that will save you from embarrassment later. I have committed this mistake couple of times in the past, and I have not repeated that since then. And the next important thing is you should always indicate the time limit and other constraints. So we are not God, and our hospital also has limitation. Like if it is a patient, if you are seeing for the first time, most likely you should give 15 to 20 minutes if it is in the clinic situation. If you are admitting that patient, maybe you give half an hour, 45 minutes. But if it is just a follow-up, the patient has come to you just for stitch removal, then you have to say, आज हामीले धेरै बिरामी हेर्नुपर्छ, तपाईँलाई आज हामी यति टाइम छुट्याउँछौँ. Plus, there are other reasons. Now we have the constant. We always prevent the patient to come closer to you, and we say, okay, there is a seat there. You sit there. I sit there. I wear mask. You wear mask. Then those kind of things you always say beforehand, so that they don't feel humiliated when you tell them late in the later part. These are these factors are very important to build rapport with the patient. And next important thing where I feel we need improvement is listening to the patient. There is a difference between hearing and listening. Hearing is always passive. Listening is always active. Listening means, hearing is like ventriculomegaly. Listening is like active hydrocephalus. So listening is always involves some pressure, whereas hearing is just, you have a mic on and that's it. And effective listening is go as these three processes. First is hearing, next is you interpret what you have heard, and third is after interpretation, what you understand from that message and how you relate to yourself. This is the ultimate step of listening. This was one very old study done by Beckman and Frankel back in 1984. How long how much time average doctor gave to the patient, allowed the patient to talk, and our tendency is when the patient starts saying their complaint, their problem, we tend to interrupt them, which is not right. And they have done the study very patiently. Even if the patient, any person who talks cannot talk more than 2 minutes, so there is no point interrupting them. There are certain outliers, of course, but the majority of the patient, after they talk for 20 minutes, they need a break, and that time you can ask them question. But Based on that same study, what they found, an average doctor interrupts patient while they are talking in 18 seconds. So we are kind of impatient. Maybe there are reason why we become so. If there are 40 patients waiting outside your clinic, then you become impatient. But that aggravates your problem. You interrupt, then patient says, "Okay, पाउनु पाउनु म त्यो ठाउँमा आउँदैछु, पहुँच्नुस् न भन्." Then again you start all over. That further increases your time. So it's best to let them talk, and they will get exhausted. Then you come in the scene. This is one interesting information I'd like to share here. Another thing is Nepali. This was like this presentation had been done in Ministry of Health and other. This is a world picture. This man is already gone to America, I think. So they got the data from the Encell, and 96 Arab the Encell was getting the revenue from the this telephone, from mobile. So we spend a lot of time talking, and we spend lesser time in listening. This is the message I get from this picture. Another important thing in communication, we should never be judgmental. Just like in research, we start with a null hypothesis that we say there is no difference. These are the two patients' prescription I had seen in my own clinic. एकजना पेसेन्ट भन्छ देब्रे कानबाट तातो हावा अनि दाहिनेबाट पनि तातो हावा 2 देखि 3 दिनलाई, and then multiple areas of pain. So even if there is no such thing as tato hava daine kanबाट आउने, but still you say that okay, you listen to that and then you feel for the patient. Then another patient comes with टाउको गिलो जस्तो अनि सियोले घोजे जस्तो maybe pins and needle, but टाउको गिलो doesn't happen. So even if the patient says some wild thing like this, still you don't become judgmental. Maybe you have that. I look into it. I'll do you detailed examination. We'll do necessary tests. We'll find out what you have. So even if the patient has no structural lesion, patient can have psychiatric problem. That still is a problem, medical problem. So this is what I wanted to communicate about being non-judgmental while the patient comes to you. And next important thing is the non-verbal communication. I have touched that little bit in earlier slide. So this is called paralinguistic expression communication. So body language could be in the form of your posture, how you see or how you stand, your head motion, your facial impression. If the patient is talking, your patient is saying to you her complaint or his complaint, you are talking over the telephone. That's not good. Or if you are looking away from the patient, you are not having eye contact, or you are doing some gesture which is not good, then all these will impair your communication. So this is I'm the wealthiest man, not just in Europe but the whole world, because I collect emotion. This is Russian President Vladimir Putin. So his boy, and they had done one survey, and he was supposed to be the most powerful man in the world at some point, 2016, 2017, because his body language, his expression, the way he talked, the way he he mobilized the mass in the Europe was just people will be envious about. So this is the bodily language and emotion that helps thing. And people have actually developed diploma course on body language, that what kind of body language is appropriate for what kind of profession. If you are going to be a banker, or going to be a doctor, engineer, or the pilot, or the politician, different body languages you have to develop to excel in their career. So body language diploma is one thing. Next important thing, which I stress time and again, is the eye contact. It's the most important way to good communication. It's the most our eye is the most expressive part, and eye muscles are the busiest muscle in the body. And on the average in a day, you spend the eye muscle move about 100,000 times a day. So eye works all the time next to the second heart. And if you have eye contact, it shows warmth and being connected to the patient. And there are many books also written on the power of eye contact, on all that. There is no subject which nothing, no such thing is written. It's unbelievable. So all I wanted to say is eye contact is extremely important in your communication part. Smile, I have said that in past, always, if you are very angry, very anxious while you are communicating, that does not help communicate, delivering your message well. So as far as possible, it all depends on the context also. If you are saying that the patient has a bad disease, you would not smile, but overall, smile helps to pass the message across in a positive way. These are people smiling, just gives positive vibe to the whole environment. Next important thing and controversial is whether you should touch the patient or not while you are in the clinic. So it's one of the important non-verbal communication, and whether we should touch or not is a controversial, but the majority of the patients and some studies have also shown that if you touch the patient in a positive way, that gives some kind of confidence to the patient that this doctor is very connected to me, this doctor is going to help me, I'll, I'm now going to trust him, that him or her. That kind of thing is obtained by touching the patient. But there are exceptions, if the patient, there are cultural issues, and there are some culture where you don't male doesn't touch the female. If it is somebody who is very respected in the society, you just don't go and touch him. If the chief justice comes to your clinic, you just don't touch him. So there are certain exceptions, but with experience you figure out whom to touch, whom not to touch. But if it is a liable situation, an elderly patient, and if you touch them, and it always gives positive impression to the patient. But there are two important rules where you touch regarding the touch. So you only touch the neutral part of the body. This is, I think, obvious. So you don't pat on the shoulder, or you don't hug your patient. Arm and forearm, anything below elbow you can touch, not in the thigh or feet or shoulder. And some people even don't like touch at all. Now, if you touch briefly and see their reaction, if they feel okay, you can touch or shake hand. Or if you don't feel they feel kind of awkward, then you just stop that touch phenomenon there. There are certain, this is overall brief overview of the general communication skill. There are special situations like breaking bad news, discussing medical error, you have left a patty or some instrument inside the operation, during operation, how you disclose, or dealing with emotionally charged patients and family. तपाईँले लापरवाही गर्नुभयो, खतम पारिदिनुभयो, those kind of patient also way. And there are special way of dealing psychiatric patients and prisoner also. There are special way how you deal with prisoner, because sometimes the prisoner try to find a way to escape from the prison, and the majority of the time it is the hospital where they capitalize that opportunity. So we have to have a special situation where we communicate with the prisoner patient. I think some in the future, this webinar, we can go one by one. And this communication skill in teaching hospital is a 7-day course also. This is a 7-day course where general communication is done and individual this thing is also done. We have a communication skill unit that is done. So today we are not going to discuss with all this special situation, but there is a way to do this. So to conclude my presentation, if you just communicate, you can get by, but if you communicate skillfully, you can work miracles. And this is how the Neanderthals, our ancestors, made fire. So if we work hard and stick to some basic principles of communication, and we will succeed in communicating what we wanted to communicate. Okay, this is my concluding slide. Thank you so much for your kind attention, everybody. So back to you, Dr. Yam. Hello, Yam. Yeah, this is the end of my presentation.
Okay, maybe I will take over. Maybe.
Yes, please. Thank you.
So I joined in about 2 minutes later, but then
I saw you that you were right there.
No, background noise jalan banda garनु पर्यो कस्तो हो?
What's the matter?
जसले बोल्न खोज्दै उसले मात्रै अब thank you very much. This is one of the most important topic that we have discussed today, and very nicely, elaborately. I mean, you talked for about 1 hour on communication, and I don't think everybody were bored, and all of the things that you have said was important. I have communication. We are all doing communication throughout since our medical school. But this is one
Yes.
thing that we keep on learning. And from today's lecture also, there's so many things I think we have learned. And every day I think personally myself, I also think that I am learning right now also, and I'm not perfect, and I need to be perfect. When I get angry with the patient, I feel bad afterward. I should have controlled my anger or something like that.
Yeah, we all go through this.
uh,
That
yeah,
this is also
and very,
sometimes you stress me.
yeah. अनि मोहनले भनेको जस्तो तपाईँको श्रीमती होइन त भनेर कतिचोटि मिस गरियो होइन,
Oh,
अब त्यो
मैले नि गरेँ।
त्यो सबैले गरेका होला नि, त्यो पनि एकदमै इम्पोर्टेन्ट कुरा हो। र पेसेन्टले चाहिँ कस्तो छ भने मलाई एउटा लागेको चिज चाहिँ के हो भने पेसेन्टसँगको कम्युनिकेसन, स्पेसल्ली दोज पेसेन्ट्स हु कम इन इमर्जेन्सी अर बिग डिजिज सडनली विथ अ लट अफ फ्यामिली मेम्बर्स, त्यो इनिसियल पिरियडको कम्युनिकेसन इज भेरी भेरी क्रिटिकल के। त्यो बेला
Yes.
उनीहरूले चाहिँ इम्पोज गर्न खोजेका हुन्छन्, उनीहरूले कन्ट्रोल गर्न खोजेका हुन्छन्, तपाईँमाथि इम्पावर्ड गर्न खोजिरहेका हुन्छन्। त्यो बेलामा तपाईँले कति ट्याक्टफुल्ली, कति स्किलफुल्ली र लुक आई एम द
Yes.
वान हु इज गोइङ टु लिड द म्यानेजमेन्ट फ्रम नाउ अन एन्ड यु निड टु लिसन, बट देन आई एम ओपन भन्ने खालले अलिअलि झर्को, अलिअलि गाली, अनि अलिअलि माया, अलिअलि केयर पनि गरेका छु। त्यो आँखामा पनि, ल्याङ्ग्वेजमा पनि, बडी ल्याङ्ग्वेजमा पनि, त्यो सबै चिज चलाउन चाहिँ अब त्यो टाइम चाहिँ लाग्दो रहेछ, बहुतै टाइम लाग्छ। कोही कोही एकदमै राम्रो छन्। हामीहरूकोमा एकजना डक्टर हुनुहुन्थ्यो, ऊ एकदमै कम्युनिकेसनमा राम्रो, र ऊ अहिले बाहिर गयो छोडेर, अहिले अहिले चाइनातिर जानु भएको छ। ऊ
Okay.
गइसकेपछि पनि त्यो त्यो डाक्टर भयो, म देखाउँछु, होइन भने देखाउनु भन्थे क्या। He
Oh.
was so in communication.
Okay.
So I think this is very important topic, and I'm sure there's a lot of questions,
Uh,
and the floor is
um,
open.
yeah. Amit, Amit, you want
हजुर
to go
हजुर
to the question and answers? So before we go to communicate the discussion.
हुन्छ नि हजुर so I would like to request you to just stop sharing so that I can share the slides.
Okay. 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 Hmm.
So thank you once again, Dr. Mohan. Well, we can now understand that communication skills is just not only a skill, it's also a scientific thing we need to know about it. So after listening to you, we have prepared some questions here, and together with, we'll also like to request for the feedback of all the participants, and then the floor will be open to all the questions. So since I will now share my slide.
After this question, after this, we'll do question answer session
Yeah.
discussion.
So now this is open to everybody. So anybody can take a scan of the QR code. It will directly lead to mentimeter.com, mentimeter.com, or you can just punch in the code as printed on the screen. Is it visible to everybody?
Yes. Yes.
Yes. So now I start the quiz. I'm waiting for the participants. Only 5 have joined yet now, out of 48.
Okay.
Well, in this menti.com exercise, the problem is that once it shoots, then I cannot stop it. It keep on going on.
Okay.
please stop me if somebody has any problem, or you can just raise an alarm here if you have difficulty in getting connected to this site.
Actually, while they are waiting, then some senior can say their share their experience. Amit,
Yeah, we can go
Basandai,
along. Yes, sir.
yeah, Ainara,
Yes,
you
sir.
question and answer.
Hello.
Uh,
May I say
yes,
something? Hello.
yeah, yeah,
हजुर
yeah.
म केही भनौँ
Basandai chairperson हो. उहाँलाई सोध्नु।
हजुर
Hello.
हजुर सर म केही बोलौँ पन सर सरको म्युट भएको छ
Hello.
म केही बोलौँ
डाक्टर प्रवीण त्यसपछि डाक्टर पवन बोल्नु होला
हजुर just wanting to share my small experience since this COVID pandemic has started. And first of all, thank you very much, Professor Mohan Sharma. As ever, you are really a very great source of information. In fact, a huge source of information. So today's topic is undoubtedly one of the very important aspect of our profession. So in this regard, I think we have learned many things, and in the days to come, as Pansar rightly said, we need to learn more and more. As we become more and more experienced, we find out more and more shortcomings on ourselves, and we need to learn more and more. As I experience share गर्न खोजेको, since last few months back, I have been experiencing that I have been having some difficulty in communicating with the patients. Somehow I am trying to say something to the patient. I am trying to ask them something, but somehow they are not understanding. They are not responding to my communication. So sometimes, at times, I have to shout and I have to ask them a bit loudly, which may sound a bit rude, something like that. मेरो आफ्नो अनुभवमा किन भइरहेछ यो कुरा आजकल पहिला जस्तो हुँदैन थियो भन्ने लागिरहेछ मलाई. Probably it is because of some sort of physical barrier, as Mohan rightly explained in his this presentation. Probably because आजकल पेसेन्ट र हाम्रो डिस्टेन्स बढी छ. मेरो कुरा गर्ने हो भने पेसेन्ट चाहिँ ठ्याक्कै ओपिडी को ढोकानिर बसेको हुन्छ, करिब करिब 4 meters apart from me. त्यसपछि I have 3 masks. I use 3 masks while seeing patient. I still need a fourth one, but I don't know exactly. And I have protective glass or this visor. त्यसले गर्दा होला, probably I feel that I am speaking loudly, I am speaking more clearly. I feel like that. But even then patient is not being able to understand. Sometimes they say that डाक्टर साहब बुझेन अलिकति अथवा सुनिएन भन्ने पनि उले भनिरहेको हुन्छ. बार देटिङ हजुर हजुर हजुर, and really sometimes I really get irritated. But that was not present in previously before this COVID pandemic started. So my query in this regard is, have you all, or I don't know how many of you are having the similar experience in your daily outpatient clinic? And if it is so, then what can be the possible solution for this problem?
Okay.
Hello.
Can I say? It's a very important thing you said. Of course, we have introduced a barrier, no? So it was deliberate because we wanted to give them service, but we wanted to protect ourselves also, and we protect them also. Actually, we are more riskier to them than they to us, kind of. And another thing, I think we are a little bit stressed out this time. We are seeing the patient that I have also felt also, Praveen, I have also felt. I feel that if the patient should go, I should not expend my time with this particular patient for more than certain time. Previously, I used to give them as long as they wanted to stay. Now I make sure they leave my clinic not more than they should leave my clinic earlier than 10 minutes, should not stay in my clinic longer than 10 minutes. So sometimes they keep on asking. And their perspective is they have taken a huge risk of coming to the hospital from home in Corona. Once they are inside, they want to ask all the questions relevant. And I have told them this also. Only yesterday, I had to tell them, okay, I have answered you enough. Please, I have also my limitation. I think you should go. I have 2 more patients to see. I told them that. And in our subconscious mind, that thing is playing out. And then that is the reason probably. Maybe Pantadai has a better answer to his question, or Pavan sir.
Hello,
Hazur.
am I audible?
Yes, sir.
Fine. Thank you, Mohan, for a very nice presentations and very useful topic, and which probably I think majority of us are lacking, because in my time, at least, this communication skill was not there in the course. Of course, when I became a teacher, this communication skill was introduced, and then I had to study about this, and then certainly transmit the knowledge. So this is a very important topic. अनि प्रवीणको क्वेसनको त पछि हामी विचार गरौँला। त मैले एउटा दुईटा कुरा के सेयर गर्न खोजेको कि हाम्रो मेन प्रब्लम डाक्टर मोहनले भन्नुभएछ कि 55% of our consultation time should go for the communication, whereas in practice we are not giving more than 10 to 15% of our consultation time. त्यसको एउटै कारण हो ओभरक्राउड। त्यो ओभरक्राउडिङलाई यदि हामीले लिमिट गर्न सक्यौँ, लाइक इन युके for a 3 hours OPD sessions, there should not be 10 patients, more than 10 patients. Until unless we can limit that, त्यो पार्टलाई चाहिँ आन्सर गर्न एकदमै गाह्रो छ। That is one part. अर्को कुरा मेरो आफ्नो फिलिङ मैले के फिल गरेको, जस्तो कन्फ्लिक्टको बेलामा कुनै पेशेन्ट मरेको छ, कन्फ्लिक्टको बेलामा I am the only single counselor and there are 20 patients and his relatives are before me, and all are putting so much of the nonsense question. Of course they are in a stress, so that कि एक्लैले जवाफ दिन पनि गाह्रो छ, and that makes a very odd situation. त्यो कुराले पनि हामीले एनएमसी बाट केही न केही तरिकाले सिंगल टु टू इज पोसिबल, but सिंगल टु 20 कसरी पोसिबल छ यो अर्को कुरा मेनी टाइम सेम क्वेशन मैले पेशेन्टलाई बुझाउँदा पनि मैले बुझाएँ, माइ जुनियर्स बुझाए, मेरो सिनियरले बुझाए, तर उले बुझ्न तयार छैन, बिकज दे आर कमिङ विथ ए भेरी मच अलरेडी डिटरमिन्ड माइन्डले आएको छ। त्यो हामी बुझ्दैन, जुनसुकै कारणले हामी बुझ्दैनौँ, जुन कि मोहनले आफ्नो प्रेजेन्टेसनमा भन्नु पनि भएको छ। अब त्यस्तो ग्रुपलाई पनि एड्रेस गर्न एकदमै गाह्रो हुन्छ। अनि नयाँ कुरा एउटा चाहिने, अस्ति भर्खर मैले डिलिजमा हेरेको छु, के गर्दैछ भने अहिले चाहिने नेपाल टेलिकमले 10 कन्सल्टेसन्सको प्रोभिजन ल्याउँदैछ। प्रोबेबली अलिअलि टक भएको छ, इट मे बी इन्ट्रोड्युस्ड विदिन द्याट। त्यो पिरियडमा मानव एउटा जुम्लाको पेसेन्ट छ, अब त्यसले टेलिफोनिक कन्सल्टेसन गर्छ भनेपछि हाउ इट इज गोइङ टु बी डेल्ट, आई डोन्ट नो। द्याट इज रियली युकेमा चाहिने म ट्रेनिङमा जाँदाखेरि यो कुरा त्यति बेला देखेको थिएँ, त्यति बेला भर्चुअल मिटिङहरूको प्रोभिजन थिएन, बट स्टिल दि टेलिफोनिक कन्सल्टेसन वाज देयर। त्यसको आफ्नो आफ्नो प्रोभिजन तिनीहरूले सेटल गरेका थिए। त हामी कहाँ कसरी गर्छ, त्यो एउटा नयाँ आइराखेको छ, हामी कहाँ कसरी गर्ने। अब अर्को प्रवीणले जुन भनेको छ त्यसमा त मैले हेर्छु कि आफ्नो प्रोटेक्सनै सबभन्दा इम्पोर्टेन्ट छ, किनभने हस्पिटलले पनि केयर नगर्ने, गभर्मेन्टले पनि केयर नगर्ने। अनि अलरेडी इन्डियामा हामी देखिराखेका छौँ 150 डक्टर्सको अलरेडी डेथ भइसक्यो। मेरो क्लासमेट 3 जना मैले देखिरहेको जसको डेथ भइसकेको छ भनेपछि वाट एभर इज देयर पेसेन्टको इन्कन्भिनियन्स छ, द्याट वी मस्ट एडमिट। आफ्नो प्रोटेक्सनै विचार गर्नुपर्छ। अनि वाट एभर प्रवीण इज डुइङ, आई डु एग्री विथ द्याट।
Yeah.
Thank you, sir. Thank you very much.
Yes.
Hello.
सर मैले इन्टरप्ट गरेँ, हाम्रो फेरि एकचोटि भन्नु पर्ला सबैजनालाई है, यो menti.com मा चाहिँ इन्टर गर्नु पर्यो। आउट अफ 43 पार्टिसिपेन्ट्स ओन्ली 17 हेभ येट इनरोल्ड। एनी प्रब्लम मैले चाहिँ चलाएको पनि थिएँ है स्टार्टिङमा, यो हाम्रो इन्स्ट्रक्सन चाहिँ भोटिङ इन्स्ट्रक्सन चाहिँ, सो त्यो चाहिँ एकचोटि स्क्यान गर्नुहोस् होइन। यहाँ क्युआर कोड देखिरहेको छ, सिम्पल छ, क्यामेरा अन गरेर क्युआर कोड स्क्यान गर्नु बित्तिकै इट विल डाइरेक्टली लिड टु दि menti.com। त्यसमा कोड पनि इन्टर गर्नु पर्दैन, तर www.menti.com मा हाल्यो भने चाहिँ कोड इन्टर गर्नुपर्छ एन्ड यु विल ल्यान्ड टु द ल्यान्डिङ पेज। अहिलेसम्म 17 जना मात्रै आएको छन्। अब पछि गऱ्यो भने फेरि यो चाहिँ क्वेसन रिपिट गर्नु सकिँदैन, त्यही कारणले चाहिँ सबैजना इन्भल्भ गर्नुहोस्। हजुर डाक्टर प्रवीण प्लिज।
Hello.
Hazur, Riam.
Amit. Hello.
Yes, Amit.
Mohan sir.
Hazur.
Thank you very
Yes,
much.
Riam. You are on.
Your excellent presentation. अलिकति मेरो इन्टरनेट प्रब्लम भएर अलिकति गाह्रो भइरहेछ कि मलाई।
Yeah, okay, no.
I think most of us we are facing almost similar communication problems because because of the socio-demographic conditions which we face in Nepal. मेरो आफ्नो पर्सनल few experiences के हो भने, like you rightly said कि अब sitting eye to eye contact हुनुपर्छ, तर sometimes के हुन्छ भने like when we ask the patient or patient party to sit down and then they keep on talking, you know, र उहाँलाई उठेर जानुहोस् भन्दा पनि गाह्रो हुन्छ. So that is one of the I mean you know problems which we face. त्यस कारणले ICU को जुन काउन्सिलिङहरू हुन्छ त्यो त म उभिएरै नै गर्छु, because if बसायो भने they never tend to leave, you know. The second thing is like most of the times we are referring the patient to the with the bed number, हैन. त कहिलेकहिले के हुन्छ भने like you know due to some so many reasons bed number change भएको हुन्छ. So you know sometimes like एउटा patient को counseling we'll be doing to somebody else. So that is a big embarrassment. So I think we should always try to address the patient by the name and not the you know bed number. And other thing is like disclosing the facts to the patient. The Western literature, it is I mean Western world is compulsory that you have to disclose to the patient. But हाम्रोमा के छ भने sometimes when you say कि brain tumor छ अथवा you know there is something that you need surgery, then the patient you know they become very emotional, you know many times they collapse also. This currently about like one like a case of meningioma, मेरो follow up you know high parietal meningioma, very you know involving the sinus. So we did an MRI after 7 years. So there was no growth in the size. So I told her, you know, there is no increase in size. And then she says, oh, the tumor is still there. This and that. She started crying. Well, even a tumor is there for the last 14 years, but there's no increase in size, so we don't have to do surgery. And again, you know, they started crying. So I told, maybe, you know, we can give a radiotherapy so that if you're so much afraid of it growing, then we can give a radiotherapy. Then she said, कि अरे यो मतलब cancer hospital पठाउन लाए मलाई cancer भएको रहेछ. So you know it was very I had a tough time to convince them. The patient party also, you know, they were I mean bachao happen. So sometimes many times I think we have to avoid disclosing to the patient herself or himself. Of course, it all should be based on the patient's you know stability also. Lastly, about due to corona, as Dr. Praveen has also said that I think the only thing which is left for us to communicate is our eyes, you know, because अब मुख पनि छोपेको छ, कान पनि अलमोस्ट बन्दै हुन्छ, voice पनि हुँदैन. So मोहन सरले भन्नु जस्तो अब only the eyes are left. So अब आईबाट नि स्माइल दिने हो कि अब एङ्गर हो, यो जे पनि गर्ने हो, I think हामीले आँखाबाट नै गर्नुपर्छ.
Absolutely.
So these are some of my you know some comments. Otherwise, it was a very good talk. And if there are any more questions, I would request the participants to either message in the chat box or you can ask directly to us. Otherwise, I would like to hand over this to our senior, our you know my senior next moderator.
Yes, Dr. Yam. So let me break in here. Let me break in here. अब हामीले वेट गरे अब यो पोस्ट टेस्ट गरिहालौँ. 18 जना मात्रै लगइन भएको छ. So I think 18 of you people can also take this feedback. So let's start. So here comes the first question. Dash context refers to the similarity of the backgrounds between the sender and the receiver. You only have to touch the right answer. Okay, so most of us has actually punched in social. It is a cultural similarity which is important.
My communication wasn't enough. It was not good communication.
No, sir, this is just a one question. Let's see for the other answers also.
So
Here comes the second
majority
question.
is the correct answer.
Letter, email, telephone are examples of. The options are So this time democracy has voted channel, and that's the right answer.
Yeah.
This is this is.
This time your communication was good.
Uh,
What body language shows you are listening? So the options are I think this must be unanimous. Okay.
Should be.
So most of
Who
us
was that
have
one
picked the
person?
right
Oh.
answer. Okay, and now to the last question. Last question of the postcard. Building a
Yeah.
relationship based on trust is called. Well, this was the title of one of the slides.
खै लभ्ने भन्यो
So this time also democracy wins.
Wrong.
Okay. So now we move to the feedback. This is a multiple choice, so you can choose as many options as you feel is appropriate for this question. And then do not forget to press submit. Okay, and the last question for the feedback. As usual, do you recommend this presentation to your peers? Please press submit after you choose your answer. Thank you everyone for your participation for the post test and the feedback. And let me also take this opportunity to welcome you to our next webinar coming Saturday, that is the 8th of August, by Dr. Binod Raj Bhandari and Dr. Gopal Sedai. The topic will be on controversies around ruptured aneurysm. So with this, I will hand over the mic to Professor Basant. Please continue. Dr. Pant, sir.
I think he's offline. Hazur,
Yeah, maybe Dr.
offline.
Dr.
Yeah, I
Achit
think
want to share his experience, and there are some questions in the audience, I think. I think we should entertain the chat box.
actually, sir, मेरो यो internet गएर I can't read the previous messages.
Amit,
Okay, let me read the
Please,
questions then.
can
Let me
you
read the
message?
questions then. With your permission, Dr. Young, Dr. Pant, I think has
Please,
been logged
please.
out, I think for some problem. So the question which has been, okay, so Dinuj has put up a question. In neurosurgery, many young patients have high-grade cancer like GBM, and the family do not want their patient to know about that. In your experience, how do you deal with that? So breaking the bad news to the patient.
Yeah, almost always you have to disclose at some point. There are ways actually how you disclose. There are ways. Maybe we'll do part 2 of the communication skill at some point, maybe a month or later. So especially how to break bad news. Dr. Gopal Sedai is in the audience. Gopal, hello.
Yes, sir.
Yeah, so he did one presentation last week about how to communicate breaking bad news. So they are the special way how you break bad news, but you have to tell that information to the patient sooner or later. The reason why you should do is if the patient develops complication and if the patient is conscious, they will curse you. If you had told me, I would have been hemiplegic, I would not have allowed you to do the surgery. So they would do that, and so you have to tell them, upfront when the patient comes in to your clinic, you see the CT scan, and in 2 minutes, you don't say that everything to the patient. You take time, let them take time, and then maybe they will come tomorrow. But you have to tell them before surgery. That's the one thing I like to stress on this time. Eventually, they will find out and they feel cheated. The patients will feel cheated that they were not told.
Thank you for those answers, sir. Well, just to add to it, what I actually also do one more thing is that I consult the attendants whosoever is asking not to reveal this fact to the patient, and I tell them that as a doctor, I have a different way of telling the disease. I won't directly say to the patient on his face that he has a cancer, is going to die of it. I will definitely be telling this bad news in a different manner. So you can also join me in this particular endeavor, and then together we can break the news. So this helps a lot if you can actually team up with those attendants who do not want the patient to know, and that's how you can actually break the news in a very gradual manner. Well, the second question comes from Dr. Prakash Paudel, and it's a very relevant one in the OPDs particularly. If there is a patient who keeps on talking beyond 2 minutes, what is the best way to stop these patients from talking?
Okay. You should do, Prakash, you should do experiment, at least do some kind of study and see. Majority won't talk beyond 2 minutes, maybe 3 minutes they will let you come in. If they keep on talking without breaking the sentence, then you have to show your body language that you want to say. Not verbally interrupt them, but your non-verbal bodily language should show that you want to come in and clarify things. That is the one way. These are, whatever I said are the very ideal ways, and but sometimes practicality also has to be taken into consideration. Like, there are 40 patients waiting outside the clinic, then you have to gently tell them, now probably you should leave. So there is nothing 100%, but try in next 5 patient, Prakash, and see how long they talk.
Hello.
Sure, sir. Thank you, sir.
One way can be like, what I do is like, if the patient is unwilling to leave the seat, I put the scan on the view box and tell them it's normal. Then I myself put it inside the bag, and tell them that it's normal. So you can go. So if you put the scans in the bag, पकडाइदियो भने अब छिटो निस्किने सम्भावना चाहिँ बढ्छ.
Well, not the recommended way, unfortunately.
Yes, sir, Yam bhai, हात जोडेर नमस्कार गर्नु बित्तिकै ल अब we are closing the session भन्ने कुरा जस्तै देख्यो त. The other question is
Okay, thank you,
by
sir.
Dr. Satish. Yeah, Prakash, you wanted to say something here. Please unmute your mic and speak. Prakash.
I'm saying thank you. Thank you for the response. Reply.
Yeah, so other question is from Dr. Satish. He asked if the patient stays for a very long time, is going to stay for a very long time in the hospital, how do you break this news to the patient party about the management for a very long time and the ongoing treatment? How often should we communicate?
Okay. This is a difficult situation again. There is no right answer to, but it's individualized. This usually happens when there is third party payment. Somebody else is paying, they want to be 100% cured after a major head injury, which doesn't happen. So it is you have to involve the hospital administrator in the part of the process. And what we say that you are saying, staying here, we have done what needed to be done from our side. Probably you need more rehabilitation and other thing, and we are not the right person to do that. So for two reasons, you have to prepare yourself for leaving the hospital. One is you are occupying the bed unnecessarily for a patient who would have benefited by staying here, because we have a bed limit. Next is you will benefit if you go to the another hospital, probably rehabilitation hospital. We usually send patient to Shanghai, spinal cord rehab center, where they have started taking care of stroke patient also. These are the two ways. And third, we involve the hospital administrator also, so they will also push. But we had a patient who stayed 18 months, so there are some outliers again. There is just no way to kick them out of the hospital, and it's not the right way.
He actually wanted to ask how often should you communicate with the patient party regarding the management or ongoing treatment? If the patient is staying for a very long time, if around 3 weeks or 4 weeks, should we communicate about the management every day, or we can just say hi, hello, and then move on since nothing else is to be done for that particular moment?
I think Rajiv will answer this question. Rajiv, Bir Ashpal. Beer and teaching are the one. Beer and teaching are the one who have the longest waiting period, maybe.
Yeah. What question Surya?
Question repeat Gaurav Amit.
So here Dr. Satish is asking whether the patient stays for a very long time in the hospital. How often should we communicate with the patient party regarding the management and the ongoing treatment? How often?
Usually, detailed discussion is done at the time of the admission. But then every day in the round, we see the patient, and if they have any queries, we answer them.
Yeah. Concur. That's what it is. And the day before surgery, we have to do detailed counseling.
True.
The day before surgery. Definitely. And document the finding, especially if they are hemiplegic or they are losing vision or you are doing a spine case. You have to document that you have discussed with the patient. So that saves you, no? Okay.
Mohan sir, thank you very much.
But I think for
my question is, probably we very often get psychiatric patient to our OPD.
Yeah.
So how to communicate that patient that you need to go to the psychiatrist? How do you do that?
Yeah, this is one of the exception. You need a physical barrier. This is a general communication. No physical barrier should be there. For the prisoner and psychiatric patient, there has to be a barrier in the table so that sometimes the patient will spit at you. Sometimes they will physically hit you. So there should be a physical barrier, and the communication time has to be kept to the minimum. These are the only two things. And based on the referral letter, you do the relevant thing. And sometimes we get mute communication barrier boy. And sometimes what we get in the normal pressure hydrocephalus patient with frontal lobe tumor, they could have had those problems. And these patients are not legally fit to give consent anyway. Those with a psychiatric problem are not fit to. So we briefly talk with the patient, and then patient should go out of the room, somebody else take care, and then we talk to the legal guardian, which is either wife or husband or children. That's the recommendation, Rajiv.
Sir, which one is better option? Written, from or audiovisual?
To communicate.
To communicate and to explain about the life.
Yes, both should be in the. And audio visual is one. If you are showing them the nature of the surgery, probably it will be better if you show them the picture of or the model of the skull and where the tumor is, how you are taking out the skull. That will, but it depends on how much time we have. We also have limitation. 5 o'clock we finish hospital and then we have to go to the clinic. These are all limitations, but despite limitation, we explain them. But the written is more important. If you give me two choices, I'll do written because that will save us from future court situation and all this. So everything we communicated to them, we have to document also. Thank you for the question, Rajiv.
Thank you, sir.
Well, I don't see any questions out here. And since we have already exceeded our time, it's already 20 minutes past 6 o'clock. So with the permission of the moderators, if in case we can call it a day, and thank you once again, Professor Mohan Sharma, for a very enlightening talk, very relevant one. And thank you, moderators, as well as the participants for making it quite interactive. And looking forward to have you again in the next session. Please be safe. Take care. Bye-bye. Thank you.
Okay. Bye.
Okay. Thank you, everybody.
Thank you, sir.